Good afternoon, everyone, and thank you for joining us online for this first webinar on leveling practical session. So this will be the first of its kind, as we were saying, and hopefully we are ready for this. We love challenges, and so we are happy to provide you some practical Shockwave tips and tricks this afternoon on novel limb areas. Just before starting this webinar, I would like to introduce quickly myself. My name is Mary-Christine Collette. I'm responsible for all educational activities around the Swiss Doloclast Academy, which is the training platform, the training organization offering Shockwave training programs worldwide. And this organization has been created by the company EMS, Electromedical Systems, based in Switzerland, in Lyon, which is located 20 minutes from Geneva, those who don't know it. So EMS invented the Swiss Doloclast method at the end of the 90s. So to come back to our webinar today, so we are welcoming Daniel Morgan, our expert in shockwave therapy. Good afternoon, Daniel.
Afternoon.
And thank you for being with us today. So just before giving you the mic, a few technical points for participants. So we will go through this practical session. We will have, if you have any questions during the webinar, please use the Q&A or the chat icon section down your screen, down below or on top of your screen, and we will take some time to answer them with Daniel at the end of the webinar. So thank you.
Yeah, perfect.
Off you go, Daniel.
Brilliant. So this is logistically been a challenge this week. Obviously, this is the first of its kind where we've tried to bring you some practical experience and practical knowledge of shockwave therapy without you physically being here. So it's been logistically a challenge, but hopefully we'll do our best in terms of trying to explain what's going on and what I'm doing when I'm trying, or well, when I'm carrying out the actual practical sessions, and we're trying to mimic clinic environment as much as possible, which is nigh on impossible in the house. But we've got my father actually is the patient for today. He hasn't actually got any pathology with him, so as I was saying to MC, I won't be using the correct settings on the machine for my father for the actual pathology, but I will run through what they are. Having said that, you know, I've got some slides. I have put some slides together just to run through some of the anatomy, which I'll do stage by stage and pathology by pathology, or area by area, should I say, really. So we'll start with the lower limb today. Obviously the lower limb, but we'll start with the foot and ankle. So what we'll do, we'll have a look at the plantar fascia, and yeah, we've got willing or not so willing participant joining us now. So when it comes to the plantar fascia, obviously majority of the pathology that we see is around the medial calcaneal tuberosity. So on the screen you've got a kind of windlass mechanism, which obviously is the mechanism that is responsible for the stretch and the compression of the plantar fascia during walking, running cycles. Now, the key thing that I wanted to highlight here is that the medial cord, or the medial band of the plantar fascia, actually attaches right down into the first ray. So it will run from the medial tuberosity here all the way down and into the first ray, or into the first digit and under. So, well, even right the way down into the dip, really. So sometimes when we are doing shockwave therapy, and more often than not, it is the medial band that is a problem as opposed to the lateral cord. But we can treat into this medial aspect, and we tend to treat locally into this area. So I'm just going to pull that down, and we're going to go into there. So we're going to go onto the left foot here, And let me just angle that down a touch and angle that up a touch. Maybe better. There we go. So realistically, we know that you have a band here. Also, what we know from a kind of histology perspective is that the plantar fascia and the Achilles are actually attached histologically, so they do come around. So in the advanced course, when we do get on into more advanced Shockwave kind of mechanisms and theories and actual more advanced protocols, we do kind of use the Shockwave and run up into the Achilles in conjunction. So that's something for you to consider. But for the most part, what we're going to do today is we're going to run into just localized into the medial tuberosity here, and then maybe run into the medial cord here with the 36 mil head. So I'll show you how I do that in clinic. I've got everything sorted and ready. Got the 36 mil head there. Okay. So typically from a protocol perspective, this is actually the advanced kind of protocol that we use. So I'm giving you a little bit of a sneak peek here. But for the others, they're going to be mainly basics. Can you just bend your knee for me? Both of them? There we go. Lovely. Right. So this helps a little bit because what I can do now is I can just place that onto a little bit of stretch with my knee. So as you can tell, the foot now is a little bit, it's more on tension if I can place that through. And that really helps with the Achilles, but it also really helps with the plantar fascia. One of the other things that we can do when we're treating the plantar fascia is we can actually just be more specific and put a little bit of stretch onto the big toe. So we can just bring that down into flexion. Okay, so we're going to just pop some gel on. I'm being very, very, very kind of tight with my gel today because I haven't got much with me in the house. So typically I'd use a little bit more, but that's maybe because I've got more of a sonographic background as well. So I just tend to use a lot more ultrasound gel and contact gel than I actually need to. So we bring that on and bring it onto a little bit of stretch. Now, what we tend to do is make a good solid contact. Now, you won't be able to hear this as well. And one of the ways that we can tell that we've got a good contact onto the area is that if it'll make a different sound. When you make a contact and the shockwave is making like a thudding noise, that means that we've got a good contact with the area. If it's making more of a tinny noise, it means that maybe we need to press a little bit firmer, or maybe we need to just relocate and re-angle. So angles are always important. So what we're going to do, we bring that in. Now, my hand will probably be in the way a bit. So we're going to bring that there, and we're just going to go. Now, for this, I tend to use, I'm using 2 bar here with my father. He hasn't got a plantar fascia issue. We tend to use starting around about 2.5 and then build up to tolerance. Now, I like to move around a little bit. Just bringing around in a nice little circle. This isn't too bad because it's a nice solid area that we can work into. Now I'm going around in circles here so that we know that the contact and we're covering as much of the affected area as possible. When we look at the pathology of the plantar fascia, we always see thickening really at the site of the calcaneal tuberosity. So we always see it right up here. And the thickening is when we know that there's a problem, often on sonographic appearance, and that's right up into this area here. Well, let me try it with the other hand. So that's right up into there, so you can see that. Now, when it comes to the actual medial cord itself, we can bring it onto a little bit of stretch, and I use the 36 mil head for this. So let me just change the head and the applicator. And this actually, it's not essential for the treatment, but it is a nice little adjunct that the patients find quite nice. The 36 mil head is a lovely applicator head to use for the patient. again, from a therapeutic standpoint, we don't really have too much of the, we're not getting high enough energies in there really. However, I've increased the frequencies here, just makes it that little bit more like nicer for the patient. Now we're going to bring that through, and we're going to just go into the medial band again. So we're going to go right the way, run that all the way down. That is really nice, working into that medial cord. Now you haven't got to use the 36mm head for that either. You could use the 15mm, and that will work more into the intrinsic musculature. And that is quite a nice way of doing it. As well, what we tend to do is we do apply forces into the lateral cord as indicated. So if we find that the lateral cord has a pathology present in it, and that may be identified on an ultrasound scan or MRI, or even just through palpation, if you find in that there's tenderness maybe more around into the head of the fifth metatarsal, then we can just use the same kind of settings. Let me make sure that's all the way on. Sorry. There we go. So same kind of settings, and we can increase the frequency a little bit just to make it more tolerant for the patient, or tolerable. We just run right the way down. Okay, so we just make sure that that's going right through that lateral cord. Now, the other thing, obviously, is, as I said, is that histologically it is connected into the Achilles. So I would tend to use, because we are going to be right on the insertion here, it's going to be very, very uncomfortable for the patient. So what I would use is the 36mm head, and you can just run over that. Now, what I could, do you guys need me to actually stop sharing the screen? Would that be easier for you? Let me just see if I can do that. I'm not sure if I know how to share. Let's go. There we go. You might be able to see me more, a lot better now in terms of the practical stuff. There we go. That easier for everyone? There we go, perfect. Right, bro. So what we can do then is with a 36mm, we can run right the way through and over. So let me just swap that and put that back on, and we can go again. So again, you're using the higher frequencies here, so 15 up into 20 hertz really, just for comfort. And we'll start that. Run. Way over. There we go. So that really, in a nutshell, is plantar fasciopathy. That is what we would use. Now, from the perspective of your kind of the areas that we would treat, intrinsic musculature, medial cord, lateral cord as indicated, and then in the more advanced stuff, we tend to run right over onto the top of the Achilles as well. And the reason, obviously, we use the 36mm head here is that it's just so uncomfortable if you're using the 15mm and you're using high energies. As we said previously in the other lectures, we need up to around about, well, from 2.5 bar up to 4 bar to be able to have that kind of therapeutic effect and provide enough energies into the tissue for it to have a response. However, from the 36mm perspective, what that does is it creates that hyperstimulation and therefore reduces pain in the immediate instance. So you can, with the Achilles, work into some of the trigger point stuff, which is more of the advanced course and the rehab stuff that we will progress through. So I've got a little booklet here that we provide to the delegates, which has your, let me get to the plantar and the Achilles stuff. which is right at the end, is the last one. There we go. So that there now shows you your protocols, your rehab, or your assessment, and then the rehab that is appropriate. So I definitely could have a look through the advanced course if you guys are interested in learning more about those. But I'll run through the basic stuff today as well now for the Achilles. Now the Achilles is one of the most trickiest ones that you're gonna ever come across in terms of, we have a 15mm head, applicator head, and we have a relatively small area that we need to work on. Now the key thing is that most of the Achilles tendinopathies, when you see them on sonographic appearance, they have localized pathology. So they could be central, it could be maybe more lateral, it could be a little bit more medial. So what we tend to do is, when we use shockwave therapy for this area, we want to cover lateral, medial, and basically the central portions of that tendon. Now, obviously we have insertional and mid portion. For the insertional, they are a little bit uncomfortable, but we always go from the lowest level that the patient can tolerate up to the highest level that that patient is tolerant to. So we start off, for example, maybe 1.8 bar at the insertion because it is really uncomfortable, and then build up to what that patient can tolerate. Now, realistically, we do want to be up into the 2.2, the 2.5s, and maybe higher. But start low, build up just to the patient's tolerance. They won't thank you if you dive straight in at 3 bar. So we'll run through that straight away, and let's get some more gel. We can pop this onto the Achilles. Now, I'll demonstrate the insertion. The insertion is relatively simple. Obviously we talk about, again, on the advanced courses, the difference in its appearance and why the insertion differs to the mid portion in terms of treatment and expected outcomes. But again, it's a completely different makeup, really. There we go, got a bit more there, and I'll pop that on. Okay, so with this case now, let's get the screen share back on for you guys to see protocols. There we go. So this would be kind of the protocol that we would use, really. Now, you can work up into one of the trigger points, up into the gastroc as well, and certainly the tib post trigger point is really important one for the Achilles. And again, we run through techniques on that in the advanced stuff. But for this one, I would tend to use the 15mm. I'm going to use the 36mm because but there's actually nothing wrong with my father, and I'm just putting him through pain unnecessarily, really. But I hope he thanks me for that. So what we're going to do, we're going to make this contact there. Now, obviously, as you said, we've got a really large applicator head here, so you may slide off a little bit, or I may slide off a little bit, but it's even harder with the smaller one. Now, for this, we can go into your normal frequencies, which are going to be kind of 8 to 12 hertz, 2000 impulses, a 15mm, okay, with a 15mm applicator. So bring it back to me, and let's go. So again, I put a little bit of stretch onto the foot and onto the calf, and we just apply straight through. Just making sure it keeps moving over, up and down. And you can slowly ramp up those pressures a little bit. I'm on 2 bar there with a 36mm, so I mean I'm delivering around about 0.03 millijoules per millimeter squared. So it's next to nothing with this particular setting. However, if we went onto the 15mm, we'd start to deliver up into kind of the 0.8s and up into the 1s, then the 1.0s millijoules per millimeter squared as we are getting up into the 15mm head. Now into the insertion, the mid portion, stuff, this is where it gets really tricky, and I'm going to try to bring you a little bit closer with the camera so that you can see this one a bit better. Okay. Well, I think we got a good angle there. Lovely. Okay. So as you see, you've got the lateral portion of the Achilles, you've got the medial portion, and then you've got this central portion of the Achilles. And we want to really try to address all of these. One of the common things that we see on the courses that patients or that delegates try to do is that they want to run right into here. And what actually happens is that they drop off too low when they just impulses are going straight into your fat pad, really. And that's not ideal. We don't want that. Ultimately, shockwaves can only affect the tissues in which they are aimed at. So if we're aiming it at the fat pad and we come in right underneath, then we're not going to have any therapeutic effect onto that Achilles tendon. So what we need to do is make sure that we are within, we're not dropping below it, and we're not going into the kind of the bursa and the fat pad that lies up deep to the Achilles. So the way that this is going to be really, really tricky one now, because I don't want to hide anything from you, but at the same time, I need to get around here. Yeah, you're good. Okay. So what we're going to do, we're going to keep that on stretch. I've got this at 2 bar at the moment on the machine. Now that will be probably around about that to start off with, and then we'll increase that as it goes up to 2.5, up into 4 bar if the patient can tolerate it. And really, that's the key, is that we need to listen to the patient and say, can you tolerate it? What is it out of 10? Realistically, if it's around about a 7 out of 10, keep it at that level, regardless of what level it's at. You're still going to have that neurological response. So don't panic too much if you can't increase that up into the 2.5s, the 2.8s, the 3 bars. We just want to try to have some effect without making the patient squirm too much. Okay, so there we go. So initially, what I've toyed around with different ways of doing this. Originally, I've done, okay, do we do like 300 impulses here, 300 impulses here, 300 impulses here, or 500 here, 500 here, 500 here? Ultimately, it doesn't matter. I think for me, I just do the 2,000 impulses all the way through, as long as I'm kind of making sure that I'm making contact with the medial, the lateral, and the kind of central part of that tendon, I'm happy. So we're going to go. Now, I tend to use my hand to direct me a little bit. I use it in a pencil grip because it's a lot easier to control. A lot of people, when they first start, will really aim to come up here. So hold it really high and press down. The problem with that is that we lose control and we end off slipping. So the closer you are to the base, really, the better the control that we have. So I tend to just do a little bit of a pencil grip. The key thing as well is that you don't need a great deal of downward pressure, as long as it's making that thudding noise that we were saying. So don't panic about that. You just go into the medial here, and then come around into the lateral portion. Yeah, you can see that. And I don't know how clearly you guys can see this on the camera, but immediately, I think you can. Immediately, we're seeing this hyperemia, so we're getting some really good blood flow to that tendon. And that's one of the good things that we see almost immediately with the treatment, is that you get this immediate response and blood flow response there. So again, you can work up into the musculotendinous junction here with a 36mm head. You can do the trigger points up into the medial head of the gastroc, up into the tib post. So we've got loads of different ways that you can work up into the leg complex and the calf complex. But for the basics, to begin with, we're just going to work right up into that Achilles. And again, making sure we get the lateral, kind of medial, and just the central part of that tendon. Okay. Now, I'm going to try to wipe here, and then we can look at the knee.
Daniel, I have a quick question from one of the participants, Lloyd, who's asking, which frequency are you using for mid-tendon Achilles tendinopathy?
Mid portion, so I tend to use between 8 and 12. It really does depend. Sometimes you can increase the, so again, if the patient isn't tolerant to that, you can increase the frequencies rather than changing to the 36 mil head. You can increase the frequencies. Realistically, it's still delivering the same amount of energy, but it's far nicer for the patient at higher frequencies. So I tend to realistically stick at 8. However, you can increase it if the patient is struggling. Rather than reducing your bar or your energy, you can actually just use increase the frequencies a little bit, which makes it a little bit more tolerable for the patient.
Okay, perfect. Thank you very much.
No problem. MC, you happy for me to go on to the knee?
Yes.
No more questions really regarding that?
Actually, there were questions concerning plantar fasciitis. Maybe we can answer them right away, or?
Oh, yeah, up to you, your call.
So, question from Tina. Good afternoon, Tina. She was asking, do you tape the area you have applied Shockwave to? And just quickly, sorry.
That's okay.
So do you tape the area you have applied Shockwave to? If so, what tape would you use for plantar fasciitis?
So I don't tend to tape it, but there is some thought process certainly in elite sport where you can use I think it's called a dye taping. It's a specific technique to support the medial arch really, and it's used with like a fixed tape. It's a zinc oxide tape. So you can use that, which is the only real evidence out there for supportive taping for the plantar fascia. And I know it's used a lot in rugby. I think it's called the modified dye taping, or which I can certainly send out that information if needed. But yeah, I don't tend to use a lot of K-tape or kinesio taping. But again, just because I don't use it doesn't mean that it's wrong or it's the correct thing to do. It just means that I don't do it because I find that the Shockwave is good enough. Anything that you add into it is going to be a nice adjunct, I guess. So it's not going to be harmful to add kinesio tape. It's not going to be harmful to have a fixed tape. It's probably going to benefit in some way. It just means just because I don't do it doesn't mean that it's the wrong thing or the right thing to do. But I don't. But it doesn't mean that it can't be done.
Okay, thank you, Daniel. You were talking about the tolerance of patients, and we have a question from Catherine asking, saying that most of her patients cannot tolerate more than 2.2 bar. What does the evidence-based research say is the best pressure level to use?
Right, so realistically, the higher the better in terms of the energies. Kind of the evidence is saying around about, I think for plantar fasciopathy, it's 2.8 bar. But again, that neurological response is going to be having an effect at around about, you know, when you're having the neurological inhibition, that happens anyway. So you can still reduce down pain, and certainly in the short term. The long-term stuff, when they've looked at it in combination with exercise, they're certainly looking at around about 2.5 and 2.8 bar. However, it does also depend on what handpiece you have. So if you have like the Power Red, for example, that is delivering up into twice as much energy at, you know, certain levels, because we can deliver up to 0.4 millijoules per millimeter squared with the Power Red handpiece. Whereas, you know, the Evo Blue is delivering a maximum of 0.18. So again, if you've got the Evo Blue, I try to increase it a little bit, but it's not the end of the world if you can. Even if you wanted to maybe do a little trick that we do is we do 500 impulses prior to starting the kind of the therapeutic effect. Really, 500 impulses are around about 15 to 20 hertz to numb that area a little bit. It creates this analgesic response, and then you can start to increase up into your higher pressures. So that's another little trick that you might be able to implement.
Okay. Thank you, Daniel. So let's go back to treatment.
Yeah, cool. Okay, so flip onto your back for me. So we're going to look at patella first. This is your bad knee as well. Right, so we're going to angle this a bit. Okay, so with the, you might be, there we go, a bit better there. So with the patella, you were all happy with that. With the patella tendon, again, what we find is that it's not really a patella tendinopathy if it's not an athletic population sample, so an athlete or someone who does a lot of jumping. It is a jumper's knee after all, and it's always at the proximal portion of the patella where we see the pathology, and it's normally deep and kind of deep lying, and the neovascular changes we see are always coming from the deep fat pad underneath. So what we always do here is we work into this area, trying to angle up a little bit. But if you do get right onto that patella, the actual patella bone, it hurts. It's a little bit uncomfortable. So what we want to be careful of is not too much pressure onto here, because it is just sending shockwave into that bone, and it can create some edema on MRI changes actually. So we want to just make sure that we are addressing again the lateral, medial and central part of that tendon. Okay, so get into the nitty gritty. I'll see if I can get the protocols up again. So from an anatomical perspective, it is actually quite a broad tendon. It is roughly around about 2 centimeters. And obviously you've got the surrounding anatomy there, which you've got your bursas underneath as well, and superficial to the patella tendon. Again, obviously it's predominantly, there's arguments about whether or not it's a ligament, whether or not it's a tendon. Quadricep tendon and the patella tendon actually are, again, histologically attached. So, that is one attachment site really. And you can see that quite nicely on ultrasound. So anatomically, there's not much to really say about the patella tendon, other than it is quite a broad one. And pathologically, we tend to see those changes on sonographic appearance, those changes deep to that tendon. That doesn't have any relevance clinically really, but it's just nice for you guys to know. So again, we always use the 15 mil head here, and try to build up your pressures. We tend to use 2000 impulses again into this area, around about kind of 2.5 up into the 4 bars again. So just trying to increase that into your patient tolerance. We do talk a lot again on the advanced course about the treating of trigger points, which will verge all the way up into the kind of the proximal area. And by treating the trigger points, there are some professors in Germany that are claiming to get maybe an extra 10 or 20% in terms of the outcomes just by the additional treatment of trigger points. So it's quite a nice one, quite a nice way to add that in. But again, we're just going to focus on the tendon and make sure that we can address all aspects of it. Now this one, I'm going to drop the pressures down because this can be a little bit uncomfortable if I do angle it up a little bit. The key thing as well is that we don't want you to, my father, because he's got a degenerative knee, I don't think that he can actually really fully extend that anyway, but we do need an element of flexion through there, which is why we've got the pillow underneath, okay? what that does is it just opens that up a little bit, and it allows us just to angle a little bit better onto that tendon. So I'm going to drop this down because it can be a bit uncomfortable. And we're going to go now. Typically, I would be standing over, but you guys can't see much there. So I'm just going to sit down and I'm going to aim down and around, okay? Just so the camera can get a little bit more. No. Ready? Born ready. Okay. Just put that running through and around. So again, knowing the anatomy of it and knowing that it's a broad tendon, you can be very tempted just to hold that there and point and angle. What I would tend to do is maybe run, see that, yeah, down and around onto the medial and again into that central part. Sometimes we can get a little bit of enthesopathy around these as well, so you can get a little bit of bony projections, which is quite interesting. But again, that doesn't necessarily change your protocols too much. You just be aware that they can be present. So the key thing is that we want to really address lateral, central, and medial again, knowing that it is a broad tendon. It is around about 2 centimeters. And normally we do see kind of, it's like a donut really. You tend to see this really dark area in the central portion of that tendon, but you can increase, it can be a little bit more lateral, a little bit more medial, depending on obviously the athlete, or well, it will always be an athlete with tendinopathy. I will also do the knee, away knee. And I'll actually set this properly because it may actually benefit. So we'll set this up. Let me stop the share again. There we go. So if you guys missed that, it's coming into there. Medial angling in, lateral angling in. Okay, so you can probably see that there's a little bit of a fusion here with my father's knee, but that's fine. So what we'll do, we'll increase this now to about 1500, 12. Okay, so I tend to go, when we're doing away knee, we obviously treat into the medial tibial condyle. Now, one of the key things with away knee diagnosis is actually palpation of the joint line, and it's normally the medial joint line. Now, this can be quite tender. Is that tender now? No, it's all right. So what we do is we'll work into there. And this is really, really good for treatment of away knee in terms of pain modulation. There is evidence in what the current literature is saying that actually we can maybe prevent further degeneration of the cartilage as well, which is nice. So we're going to go into there and we're going to just put 1500, 2000 impulses in, and we're just going to see what, kind of how this response goes. It may jump, and be careful. I don't normally sit down this end in case they do kick out. Okay, so it's quite possible. So just be prepared for that. Which is why I would tend to be sitting over this side, but I don't want to get in the way of the camera. Okay, so we're going to go into there. This is 2 bar, 1500 impulses, 12 first. And there it is, starting to get a little bit uncomfortable there. So. You can take some deep breaths as well. So. Now what the patient finds is immediately after this, it does feel really light. And there is an almost immediate, definitely an immediate pain relief. Now, So we're a third of the way through there. If you become a little bit more medial, they tend to be a little bit more uncomfortable. Again, you could really be increasing this pressure as the tolerance and the pain levels drop. Tolerance increases and the pain levels drop. Now we've got 500 impulses left. It's going to be about 10 seconds now and then we're done. Lovely. Okay, so there's 1500 impulses right in. And what you find is that can be quite painful for them, which my father has just absolutely expressed. So what we can do, normally we'd retest this now, and obviously we'd have the patient to walk around, but he's got a few more conditions to run through. But we'd have him walk around and see it, and it does immediately feel, well, actually, we can try that. Go on, have a little sit, let's have a see. And does that feel like that for you? Yeah, moving better as well. So, and I haven't paid him to say that, I promise. So that's really, and it straightens a bit better as well. So it does really, really work. I wanted to tell you a quick story about a patient that I had prior to lockdown, actually. And he had 3 sessions of Shockwave once a week for 3 weeks. Far away, and he's a butcher, and he stands all day, and he just generally struggles in his shop. And he came to us, and he came to us for low back pain, and we kind of deciphered that his low back pain was because he was carrying his leg. So we thought, right, well, let's treat the leg and the knee as well, because what's the point in treating your low back, making you symptom free, and then it's going to regenerate and you're going to get more pain as time goes on. So we may as well treat the cause, not only treat the symptoms. So we treated this. On the 3rd session, when he came back in, he said that he'd walked 10,000 steps in the day and had absolutely no pain, and was able to stand all day on his feet in work with no pain. So that was absolutely amazing for me. I was like, okay, that's amazing. And he was delighted with it. So can really help with that. So MC, do you want to go through the questions at the end, or do you want to do them as we go condition on condition?
Actually, we have a few questions concerning knee conditions. Okay. Same question actually from Jake and David. How would you treat chondromalacia patella?
Oh, interesting one. Chondromalacia patella and patellofemoral pain, they are quite difficult. It's not on our accepted list, really. They are experimental. But I probably wouldn't, because chondropatellomalacia, it is a degenerative change of the underside of the kneecap. So and it's normally in an adolescent as well. So because it's in an adolescent or a teenager, we have to be careful around the growth plates, even though we know Osgood Schlatters is safe. We still have to be a little bit more careful with a teenager. However, if we are talking about kind of retropatellofemoral pain, you can certainly work around onto the tender points. So let me get that back onto the knee. So what we tend to find is that up into here, onto the medial superior portion of the patella, you can work around and angling under. That does work quite well. But when it comes to obviously true chondropatellomalacia, that tends to be early degenerative change of the cartilage, and it's normally in teens. But if you're not talking retropatellofemoral pain, then we could work around into there. There's no problem in working under. The guy who does use that quite a lot in the UK is Paul Morrissey. And Paul is brilliant. I mean, he's got a couple of books out at the moment that are free of charge as well. So it might be worth looking at Paul's stuff for more information on that. But I tend not to use too much of it, only because it is a little bit, it's not our accepted list.
Okay, thank you, Daniel. We have another question from Irina regarding osteoarthritis, knee osteoarthritis. How often the patient would need to return? Whenever symptoms return?
So I tend to do once a week for 3 weeks, and then exactly that. As the symptoms start to return, you can do the same protocol once a week for 3 weeks. I haven't. That was about 8 weeks ago that I last heard of the gentleman with the knee pain, and obviously the clinic is closed, so he wouldn't necessarily think to contact us. But we have got our clinic pages open that they can access an email, and they're all aware of that. And I haven't heard any negativity from him saying that he needs more sessions or inquiring, are we open? So good news really thus far, 8 weeks in, I'm assuming. But yeah, what we tend to do is as that pain and symptoms start to develop, we can do more sessions. As we said, there's no maximum amount of sessions that we can do in the literature regarding safety. So we can start to increase, well, not increase, but use it for pain maintenance and management.
Okay, perfect. Thank you. Another question concerning knee conditions. Can cryotherapy be applied after the session? Yeah,
so cryotherapy, there's a load of mixed reviews, and the reason why I'm hesitating with it is that we used to think that cryotherapy and ice was having this anti-inflammatory effect. Now, I don't think that that's necessarily truly the case. I don't think that, you know, anything that we're trying to restrict and increase blood flow may aid the condition. There's no doubt about that. So yeah, there's no reason why you can't use ice, heat. A lot there is, I think, some literature coming out now with the kind of combined cryotherapy treatment alongside shockwave therapy. Chris Doughton, who obviously involved with EMS, knows a gentleman, I think, who was based in London, who has a cryo chamber and seems to be getting on really well with the use of cryotherapy with shockwave therapy. So it can certainly be used. There's no reason why you can't.
Okay, thank you. We have now a question coming from Kathy KM. Sometimes patients develop bruises after the session. Is this a normal phenomenon? Is this natural?
It's not normal, but it can happen dependent on their medications. So if they're on any anticoagulants, or, you know, if they're, again, which is a contraindication or at least a precaution, but it can happen. It's not essential. It's not really normal for bruising to occur, but it can happen. Some people are more prone to bruising than others, but we don't want that to happen, because bruising is essentially a sign of damage. So we don't really want to be putting too much energy into it that the patients are bruising, because it does maybe mean that we've done too much. But again, you're not wrong in the sense that it is possible to get bruising, particularly if they are on medications such as blood thinners or, you know, otherwise. So just be aware of that, really, is that we don't aim to bruise, but it is sometimes an unwanted side effect.
Okay, perfect. Thank you. And coming back to your statement about cryotherapy, we have someone saying we should not use ice or cryo immediately after the first shockwave session, as we want the inflammation process to start with.
Yeah, so this is the underlying theory here, is that we're assuming that ice has an anti-inflammatory effect. When the literature, there's no actually solid evidence out there now to say that ice does have this anti-inflammatory effect. Realistically, all we know is that it creates a vasoconstriction, and therefore we can, as we take the ice off, we'll get this blood flow and rush of blood flow back as it starts to heat. So the actual, I agree with, this is why I hesitated initially, is that I agree with the thought process is that if ice does produce an anti-inflammatory effect, then we need to avoid it. However, there's not enough evidence out there to say that ice does have an anti-inflammatory effect. So when I agree, and it is something that you may want to consider, but from my perspective, I haven't found that it's been detrimental. But having said that, you know, if you want to use it, you could. If you don't, then don't. There's no problem with either, as far as I'm concerned. But I do understand that thought process is why we wouldn't, or why you might not want to. But again, from the most recent literature, we don't really know if it is having as much of an anti-inflammatory effect as what we originally thought.
Perfect. Thank you, Daniel. If you would like to continue with treatment.
Cool. Okay, so we'll look at the hamstring. The hamstring is a good one. So we'll look at these. I'll need you onto your front if you can. Okay. Not bad though, friend. I can't get it in. No. Right, lovely. Right, so hamstring. Talk you through the anatomy first, and obviously what we know is that the hamstring is comprised of, certainly proximal hamstring tendinopathy, comprised of really three tendons. We've got your semimembranosus, your semitendinosus, and then your bicep femoris. Now, the bicep femoris and the semitendinosus actually create one tendon, they create one solid attachment point. But the semimembranosus, although it's the medial muscle, it actually attaches quite laterally. And what we also know is that the sacrotuberous ligament and the bicep femoris, they tend, if the bicep femoris and the semitendinosus are involved, the sacrotuberous ligament actually reinforces it with stability, because they are, again, histologically attached from an anatomical standpoint. So one of the things that you may want to consider is, you know, what tendon is the actual pathological tendon with a proximal hamstring. More often than not, we find that, as I said earlier, you know, Shockwave can only affect the tendons in which we're aiming it at. So angles are really important with this one. But we tend to find that it may be more the semimembranosus. So if it is a semimembranosus tendon that is involved, we want to be a little bit more lateral with our approach. Now, you can do this exactly as we are here, laying down on your front. So let me just change that. So laying down there, or we could do it side laying. Now, for this example, I'm going to do it here. I'm going to just bring you around a bit so you can see more there. I'm going to bring this up there. Okay, and I'm just going to pull this up. Okay, so we're going to go into your common hamstring insertion. Is going to be here. Is that a little bit tender? Tiny bit. Okay, so it tends to be about here. Now, we demonstrate this nicely with some sonographic appearance usually, so you can actually visualize where that tendon attaches. But as I said, the semimembranosus actually comes medially and then attaches more laterally. So that is over into there. And it's actually maybe onto that ischial tuberosity there, we want to be more into this angle. So again, it does depend on, you know, this is where your diagnosis is important, but it does depend. Normally it is a semimem, but you can attach right into here and come in from this angle. Now, this is one of my best and most favorite treatments to administer really with patients. I've not failed to get one of these back to sport, which is a big claim, but one that I'm very happy with. So what we'll do is I'll show you what I would usually do, we normally go up into around about 3 bar. I'm very unforgiving with this one. And we normally start at around about 3 bar and then obviously go to patient tolerance. Now, I'm going to have to be there. Can you see that? Yeah. So just spread the gel around and come into here. Now, I'm currently on 2 bar, but again, my father hasn't got anything wrong. And you can also work into that myotendinous junction, and normally just add a little 500 impulses into there as well. But for this, it's important that we get into here and angle that way. Okay, so we're coming from lateral to medial, based on its anatomy. So, and you can run just through angling in. Then, once you've done your 2000 impulses there, you can work into the myotendinous junction and work down. Obviously, I'm handling this a little bit different to how I usually would because of the camera, but I'm going to run through and down into there. Right. Now, again, you can work into the trigger points and look at those. And again, that may be providing you with an additional benefit, or the patient with additional benefit. So that in theory is the hamstring. You can also do a side lie in. Now, when we do a side lie in, I'm not going to actually physically carry it out for you here. Yeah, we may as well as you there. But lay onto your side for me if you can. Just face that way. There we go. So again, we bring the knees up into 90 and 90. That just opens that up nicely and puts a little bit of stretch, and we can feel right into the ischial tuberosity as we're coming round. And then, so that's going to be right into there. And then your semi-memb is going to be around here. Okay, so that opens that up. That then is nice for you to be able to just angle in. Okay, so you can work that way, which is quite nice. Or you can do it as prone. No reason why you can't do either, but equally good ways of doing it. It's more the settings and the angles that are important for this one. So there's those. As we're in the side lying position, we'll do the gluteal tendinopathy as well. Now, this one may be logistically difficult to show you, but I'm going to try. But no, you're right there. We're going to pop that there. I'm just going to get the hip. Okay. So let's see. How will this work? I think we'll be all right, you know. There we go. Okay. Yeah, so you are mounted here now onto my onto the Shockwave machine. So when we're looking at your hip, right, I'll run you through again the anatomy here. So again, we're looking at the hip complex, okay, and we have, when it comes to the attachments of the gluteal musculature, we have really 3 or 4 different attachments depending on the glute max, because the glute max really, I think around about 70% of the glute max fibers actually attach into the ITB. So the ITB and attaches right the way down into obviously the knee. So into Gerdy's tubercle around into the front of the knee here. So realistically, we're looking at 3 possible pathologies. So we're looking at maybe a glute med, glute min, and potentially a glute max. Now, what we find with glute max tears is that they are particularly debilitating. So the patient is often limping with this. So you have to be very aware that the glute max can tear, and you normally will be able to differentiate that from your physical exam. Now, the protocol here is that because we have your 3 different attachments, you have your anterior facet, you have your lateral facet, and then you have the posterior facet of the greater tuberosity, or tubercle of the hip. We really are looking at glute min at the anterior, and then we have your lateral facet, which is going to be glute med, and then we have the glute max, which will run around. Okay, so for me, what I do is I apply 1,000 impulses into each and around. Now, that is 3,000 impulses through a treatment, but absolutely fine. So your anterior facet, usually you know your glute min because it angles directly up into the anterior ASIS really. So you're looking at this angle coming up into here. Sorry, excuse me. And this there is where you want to be with your first 1,000. Then your lateral facet is going to be coming around a little bit more, and we're going to be into there for your second 1,000. And then for the glute max, you can work around into here if you wanted to, or just into there. Now, equally, if you are specific with your diagnosis and you've got some investigations or imaging, you can focus on the relevant tendinopathy. So whether or not that is your glute min, your glute med, or your glute max. Be aware that these can tear, and obviously the patient population that we're looking at is normally your older population, so they are more susceptible to tearing, not from Shockwave, but in general. So just be aware of that. But again, this is a game changer in clinic. It does really, really help. So 1,000 impulses per facet. Again, go into patient tolerance, and I tend to use around about 8 hertz for this. And then we just aim through. So let me get some of the gel. The one there as well. So 1,000, 1,000, 1,000. Okay. Make sure I'm on that. Bring that up a bit. There we go. Yeah, right into the anterior facet there. Okay, so we do that for 1,000. When I would come more onto the lateral facet there, your glute med for 1,000, and then if you really wanted to, you can work around there for 1,000 for your. See that? There you go. Work around. Okay. So pretty much self-explanatory in terms of directing that. Yeah, and that's your protocol there. So we tend to. Do you want me to do that again on the larger screen for you so you can see? Okay, there we go. So anterior facet, like I said, angled up into the ASIS there. So coming round and in. Again, not really got the best control here, but do that there. 1,000 impulses there, coming round into here. And angling down a little bit. So changing from there to there. And then we can just bring around the back. Okay, so that is the hip really. The kind of the basics of the Shockwave there for the hip, well, for the lower limb. Is there any questions based on that one?
Well, Daniel, thank you for this, for showing shockwave treatment on the hip. We have a question. We were told 500 impulses per area, but now it's 1,000. Is that right?
Yeah, so I use 1,000. I've got no problem with 1,000. You can use 500 if you want, but I use 1,000. And I know Johnny, a colleague of ours as well, obviously uses 1,000. They do vary between practitioner to practitioner. Everyone will have their own individual way. So it does depend on maybe who has taught you, but yeah, for me, I use 1,000. You could use 500 if you wanted, but I use 1,000. So either way, there's no real, like we said, there's no right or wrong way. I just think the angles are really important. I think, and providing you've got enough energy and enough stimulus into there. But I use 1,000, so no issues either way though.
Okay, thank you, Daniel. We have a question from Jake asking if what kind of rehab would you recommend for proximal hamstring tendinopathy?
Okay, so from a rehab perspective, we start on phases. We do a phase by phase approach. So we need to look at kind of phase 1, phase 2, phase 3, and it very much depends on the patient's ability and what the your exam shows. So we tend to use things that will highlight your upper or stress more on the proximal hamstring. So like Nordics, for example, they're great for the muscle belly, but they don't put a lot of emphasis onto the actual proximal hamstring. Things like arabesques and that type of thing do. Our protocol, let me just check that for you before I go digging in. Yeah, so we want to start really early with just isometric bridge progressions and some basic hamstring curls, and then work into maybe gradually building into step ups and rollouts with the hamstring, and then more into plyometric phases. So jumps, alternate legs, that type of thing. So we tend to keep it simple for the patients because you don't want to overload them and say you need to do this, 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 and this. Like for phase 1 and then 6 exercises for phase 2, and then they won't do it. So what we've done is we tried to combine 2 exercises per phase, which it gives you the optimum load. So isometrics to begin with, just to reduce pain, and then we start to build up into maybe a bit of strength through a range when you're isolating that tendon a little bit more. And then we get you into plyometrics, which will be your return to running preparation exercises.
Thank you, Daniel. We have another question from Irina asking if you would treat patients suffering from lupus.
From lupus? Is that the, is that systemic SLE?
I think so.
Medically, pardon?
It's a tricky one.
Yeah, so are we talking systemic lupus, or are we talking like discoid lupus, or there's different obviously types of lupus? I'm assuming that
I would assume it's systemic.
Got it. Lupus. Patient was on steroid tablets, so systemic. Fine, perfect. So you've got to raise the question. So this is a discussion that you have to have with the patient and possibly with the medical team that is looking after. Right, perfect, with plantar fascia. So this is something that you want to discuss with the medical team and the patient. So what you've got to look at is, firstly, if the patient comes off the steroids, what's the effect? What effect is that going to have on her overall health? Is that going to be detrimental to her? And for me, if the steroids aren't, would they be anti-inflammatory steroids? Is that what you're concerned of, or are they just steroids in terms of her breathing? I'm reading Anna's comments in the chat. Anti-inflam. Right. So anti-inflam steroids, again, they're going to be more of a, it's going to have possibly a contradictory effect onto the care. But if it helps, you know, what's the next stage for her really is the next question. There's no reason, it's not going to detriment her health if she has it. But it, you know, you may expect limited outcomes because of it. Or it may take that little bit longer. Obviously, she's got SLE, so that in itself brings out a component, a different component, and different. But in itself, that brings difficulties with managing any patient. So realistically, it's not going to be detrimental to her health to have Shockwave. So I'd be okay with it. It's just whether or not, you know, it's not gonna be detrimental to her. It's just whether or not you explain the reason as to why we want you to come off them. But obviously it's not feasible in this case. So yeah, you should be fine with it. Oh, she did come off them. Okay. So if she came off them, yeah, it depends on as well, like kind of how bad she is and whether or not she's in a flare as well, and the stages. Well, I've got a few patients with SLE, and you know, for certain periods of the time, she's okay, you know, and then other times she needs their medication. But at the moment, you know, if they come off their medication, you can do it. It's only going to be for the best part of 6 weeks anyway. And again, like you said, it's a trial and error, and you've done the right things there by having the communication with the consultant. Ultimately, it falls back on them. So, you know, they're in charge of her care or her overall care, and have signed it off for that. So no issues at all. You know, from me, medical legally, you've had the conversations, you've done the right things, and you know, you're carrying out treatment, so it should be fine. It's always one of those ones though that is difficult, because if you discuss it with the relative people or the relevant people, the patient, explain the risks of coming off versus the risks of not having Shockwave. I mean, if you're looking at something that's a little bit more significant, maybe in terms of bleeding, and you know, if you've got a patient who's you know, haemophiliac, and if you damage any tissue, they're going to bleed to death. You know, you just wouldn't do it. Whereas if it's something like, you know, they're on anti-inflammatories, can they afford to come off them for a couple of weeks? Fine.
Thanks, Daniel, for these recommendations. We have many questions coming now. And we have a question from Akin coming back to the EAP treatment concerning grade 2 trochanteric pain syndrome. What is the protocol for treating this indication with shockwave therapy?
For grade 2 trochanteric pain
syndrome, yes.
Yeah, so right, so what we tend to do, exactly as I've just run through there, really.
Yeah.
I know I've said that it's gluteal tendinopathy, and the reason why I put gluteal tendinopathy is that grade 2 trochanteric pain syndrome is realistically a umbrella term. So we have a multitude of conditions that fall under that, like a bursitis, tendinopathies, partial thickness tears, etc. What we tend to find is if it's a true tendinopathy, it responds really well. Sometimes, you know, you're not going to have a tendinopathy without the bursa or whatever, but it then comes down to what's the pain generator. So for me, I use, again, if it's a true tendinopathy, again, likelihood is you may have some bursal involvement, but I'm not too concerned about that. If there's a tendinopathy there, we'll treat the tendinopathy. So if there is a little bit of tendinopathy, we'll go in with the 1,000 impulses per facet, and then I tend to work down into the ITB with the 36 mil head as well, and I also work into the trigger points up into the glute med, the glute min.
Okay, thank you, Daniel. Do we have time for a last question?
Of course, yeah.
So we have a question from Kelvin from Osteopathic Clinic. Can shockwave therapy be used for bone spurs, in calcaneal bone spurs?
Yes, yes. So it's really, really good. And again, what the question here is the calcaneal bone spur actually a pain generator or not? Because is it a typical plantar fasciopathy with a calcaneal, enthesopathy? So realistically, it doesn't actually change too much. It doesn't change your outcomes. So it's treating like any other chronic plantar fasciopathy. So yeah, no problem at all. It depends on, so what people, and the common misconception is that you want to break down that bone spur. We're not able to provide enough energies with shockwave or radial shockwave therapy to actually destruct bone at this point. So, and it's also some evidence out there, if we do destruct bone, actually you're just encouraging osteophytic turnover. So you're actually just encouraging bone growth, which could potentially, enhance bone spurs, not be detrimental to them. So what we want to do is that we just work on any other, treat it as any other plantar fascia or Achilles, incisional Achilles. So no problems with that at all.
Thank you, thank you. Question from Claire. Are there any contraindications with ankylosing spondylitis patients?
So again, I tend not to use shockwave with AS. It's an inflammatory condition. It works really well for your typical mechanical low back pain. I mean, like by that, I mean, I wouldn't be directing the shockwave into the SI joints, and it depends on the stage of the ankylosing spondylitis, how much fusion or ankylosing is taking place. Is it just inflamed? Are they going through cycles with it? I think for the most part, you may be able to use it in a side lying position into the musculature. There's no reason why you can't do that. I wouldn't be directing a lot of energy into the joints. So.
Thank you, Daniel. A more general precaution question from Anthony. Historically, we have been told to advise people are not on NSAIDs for 2 weeks prior to commencing shockwave. Is this the case?
Yeah, so I prefer if my patient isn't on NSAIDs for 2 weeks prior to care. Realistically, again, it's having that outcomes, or it may prevent the desired outcome of the session or the treatment in terms of enhancing a inflammatory effect. So we take patients off for 2 weeks prior to commencing, and if they've had a corticosteroid injection within the recent 6 weeks for the upper limb and 8 weeks for the lower limb. So any anti-inflammatories, we prefer if they take them, like get rid of them for 2 weeks prior and during the sessions. And then for steroid injections, we prefer if there's 6 weeks or 8 weeks for upper and lower limb respectively.
Okay, thank you. Yeah, remaining in the general questions, how often can shockwave therapy be used for a chronic pain patient?
Say that again, MC, sorry.
How often can shockwave therapy be used for a chronic pain patient?
So typically we use it once a week for 3 weeks, review in 4 to 6 weeks, and then start again then in the following for another 3 sessions if required.
Okay, so on a long-term basis, well, depending on the indication.
Yes, yeah, absolutely.
Okay. Other questions concerning osteoarthritis. A question from Julia. Have you used shockwave on osteoarthritis of the first metatarsal phalangeal joint, hallux rigidus or hallux limitus? And if so, what's the protocol?
So I haven't. Again, because I'm a chiropractor, I tend not to see a great deal of hallux rigidus or hallux limitus. So I don't tend to use it in clinic, I'm afraid. But again, I think that it depends on what you're aiming for and as an outcome and what your goal is. So realistically, you want to, if you're looking at pain limitations, absolutely fine. You could use it. I don't really know what the dosage is, but I can certainly try and dig that out for you if you would like. So I'm not too sure on that one, on specific condition with that one at the moment, but I can certainly try and dig that out for you, Julia, if you want to try and contact myself later on or contact MC. And I can answer that again with a little bit more of a heads up, really.
Yeah, I'll keep this question in mind and keep
Perfect.
notes that we need to get back to Julia.
Yeah, thank you.
Last questions. A question from John. Also, if a patient is on anabolic steroids or other performance enhancers, does that affect Shockwave outcome?
Outcomes?
Yeah.
Not really, no. What we tend to find is that obviously you've got to be careful with the muscle bulk to tendon ratio, because again, they tend to be susceptible to tears, particularly pec tears, etc. So yeah, it doesn't really affect outcomes. And the other concern is that with steroids in particular, there is this increased risk of, or perceived increased risk of vascular changes. So again, you just want to be a little bit aware of those when taking a history, really. But it shouldn't affect outcomes.
Thank you. General question which came at the beginning, how do you describe shockwave therapy to your patients? Because some of them may be afraid of shockwave therapy.
Yeah, so all I tend to say is that, look, it's what we're trying to do is put some high energy sound waves into the tendon or the affected area. This has multitude of effects. So this can increase the inflammation, which is needed because it's a chronic condition. And when we say chronic, explain the chronic pathology and what happens with chronic conditions. And then we say, so we'll then also have an effect, we almost numb the area, so it has an analgesic response, and therefore it allows you to walk that little bit better or do whatever it is that little bit better and pain-free, and allows you to rehab your condition that little bit easier as well. So it's just, I also have a consent form which explains, obviously the processes, which is useful. So they can read that, and as well then as me describing the process to them and what to experience. I think that getting it used to what it sounds like and even putting it onto a non-painful area first, all of that really helps to get them comfortable.
Okay, thank you. A question from Anna. Is there any effect if we stop the impulse in the middle of a treatment? Let's say we will change the bar, then we stop the handpiece and start again after that.
So realistically, it's nicer if you get a general ramp. So rather than stopping and starting again, the reason is that if you stop and then start again with a higher pressure, the first impulses are almost like you're starting again. So it's easier if you get a gradual progressive load for the patient. So it's not detrimental really to the care, it's just nicer.
Okay. Last question from Irina, who asked at the beginning, can we use tiger tape?
Yeah, fine. Tiger tape, I'm assuming, would have been for your plantar fascia taping. Yeah, tiger tape exactly. And zinc oxide, yeah, absolutely fine.
Okay. We are coming to the end of our questions. Question from John, what a difference in upper and lower limb in terms of steroid shots?
Yeah, so this is, it's an interesting one actually, and I think it's probably more to do with the fact of weight bearing. So because the lower limb is a weight bearing tendon, or more weight bearing tendon structures, it's more to do with the risk of rupture than anything else. So from the perspective of, obviously, when you have an injection, there's a perceived increased risk of rupture, and that, to me, is more due to the analgesic response, so that it's now numb, that you can actually load it more. So because the lower limb is greater weight bearing than the upper limb, that risk is increased. So we just wait that extra 2 weeks. That's my perspective of it, but it's also just what the literature says. So.
And very last question. So if a patient is midway through a Shockwave course with you and then goes off and has a steroid injection, should we refuse to continue the course?
Yeah, absolutely. I would. I feel like, if it's not, I don't know why they would. And I think that some people, patients do take it off their own back, think, oh, well, this isn't working, I'm going to do it. But I think if it's not a part of your plan, I'd say, right, well, we need to, you've caused this, we have to wait another 6 weeks before we can commence again.
Okay, perfect. Thank you, Daniel. We have answered all questions from our participants. We have extended a little bit the time, the timing of our webinar, but it's so passionate. So thank you, Daniel, for this first webinar on the lower limb practical Shockwave session. Thank you very much for providing all these tips and tricks, very important for practitioners in their daily practice. We will come back next month, probably in May, with an upper limb practical session. Thank you all for participating in this session. It was great. Thank you for your interaction with your questions. Thank you for sending also your questions by email. We will answer them. And please consult regularly the planning of our courses on our SDCA website because dates are regularly updated and you can register anytime. Also, we hope that we will be able to organize our practical sessions, physically speaking, in June. So stay tuned and stay connected on our SDCA website. If you have any questions to ask us, me or Daniel, feel free to keep in touch with Daniel on his Facebook page. And that's it for today. Thank you again, Daniel, for sharing.
Thank you for having me.
Thank you for your great patience as well.
Yes, yeah, he's gone now.
And so we come back next month with a new webinar. So stay tuned and take care, all of you, and see you next time online. Thank you very much.
Thanks, everyone.
Bye-bye.
Bye.
Bye-bye.